Knock, knock. Who's there?
Oyster.
Oyster who?
Oyster the pot. The chowder is burning.
You're listening to Weird Medicine with Dr. Steve on the Riotcast Network, riotcast.com.
I've got diphtheria crushing my esophagus. I've got Ebola virus dripping from my nose. I've got the leprosy of the heart valve, exacerbating my incredible woes. I want to take my brain out and blast it with the wave, an ultrasonic echographic and a pulsating shave. I want a magic pill for all my ailments, the health equivalent to Citizen Kane. And if I don't get it now in a tablet, I think I'm doomed and I'll have to go insane. I want a requiem for my disease, so I'm paging Dr. Steve. Dr. Steve! Yo, take a scalpel. To the vertebrae. I need some suction.
It's Weird Medicine, the first and still only uncensored medical show in the history of broadcast radio, now a podcast. I'm Dr. Steve. And this is a show for people who had never listened to a medical show on the radio or the internet. If you've got a question you're embarrassed to take to your regular medical provider, if you can't find an answer anywhere else, give us a call. 347-766-4323. That's 347-POOHEAD. If you're listening to us live, the number is 754-227-3647. That's 754-double-deuce-penis. Follow us at Twitter at Weird Medicine, at Lady Diagnosis, and at DrScottWM. And visit our website at weirdmedicine.com or drsteve.com for podcast, medical news, and stuff you can buy, or go to our merchandise store at cafepress.com/weirdmedicine. Most importantly, we are not your medical providers. Take anything you hear on this show with a grain of salt. Don't act on anything you hear on this show without talking it over with your doctor, nurse practitioner, physician assistant, pharmacist, chiropractor, acupuncturist, yoga master, physical therapist, or whatever. And please don't forget, go to stuff.drsteve.com. That is your gateway to Amazon. Just go to stuff.drsteve.com anytime you want to use Amazon. You just click through. There's a banner up at the top. You can just click straight through, and you can shop at Amazon. We are a member of their affiliate program, and all the information's on the website. But please do use that, stuff.drsteve.com. When you want to shop online. Also, tweakedaudio.com, offer code FLUID, F-L-U-I-D, for 33% off, the best earbuds for the price on the market and the best customer service anywhere, bar none. Also, check out Dr. Scott's website at simplyherbals.net. And if you are interested in Blue Apron, go to blueapron.com/medicine. And lastly, don't forget premium.drsteve.com. That's premium.drsteve.com if you're interested in listening to the archives of the show. It's $1.99 a month. You can sign up for 1 month, download everything if you want to, and then log off. And it's really easiest to use that using the Weird Medicine app that's available on Google Play and at the iTunes Store. Anyway, and thank you for all of that, and thanks for indulging me talking about all this stuff. In this show, on the SiriusXM show, we had a very, I think, important conversation. Nothing I do is important, but it was about, I think the topic is important. It's about chronic pain patients and what they're going through. Given that we have this quote-unquote opioid crisis of prescription drugs, and it is a real problem. There's no question about that. And there's too many pills on the streets, and the knuckleheads out there are ruining it, though, for the people who actually need these pain medications. And so now everybody's being seen as a drug seeker. And doctors are afraid to write it because they're afraid the FDA is going to come after them, or somehow the CDC is going to come after them. And it's something I'd like to do a more in-depth show about sometime in the future, because this is something I actually know quite a bit about. But I just wanted to play for you we're going to be on vacation for the next couple of weeks, so it's my kids' spring break. So this week we'll play this segment from our SiriusXM show. Next week will be a best of, which I think I'm going to pull one of the older shows, maybe the oldest show that we ever did, and let you guys hear that from 2007, the very first SiriusXM show. It'll either be that or the 3-hour Turd-tacular that we did for Danny Ross when he was running the Saturday Night Virus thing on Saturday nights. Anyway, we'll see. We'll worry about that next week. But this week is a phone call from one of our Twitter followers named Peppermint Patty, and she wanted to call in and talk about chronic pain and chronic pain patients, and this is her call. Peppermint Patty, area code 303, you're on Weird Medicine.
Hi, Dr. Steve.
Hello, how are you?
Hi, Dr. Scott. Hi, Andy.
Hey, how are you?
Hi.
So what's up?
Well, I wanted to call and kind of talk about what's going on with the chronic pain patient people.
Yeah, let's talk about
I don't
that.
know if any,
Yes.
I don't know how many people know what's really going on, because I've been surprised in conversations with, like, even nurses and things, how unaware they are with the CDC guidelines. But for me, on a personal level, it's been devastating, and I know there has to be many other pain patients going through this.
Sure. Well, let me give everybody some background, and then I want to hear about your case personally, and then we'll talk about the sort of the greater issues that are involved. So back in the 70s and 80s, doctors were told that we were underprescribing pain, or underprescribing for pain, that people with chronic non-malignant pain should be treated with strong opioids. And we listened. So we said, okay, I guess we've been doing it wrong all this time. So we started writing a lot more long-acting, strong opioids for people with chronic non-cancer pain. And there were some people that took that, found that there was a way they could make money off of it, and took it to an extreme, to the point where, you know, the market got flooded with pills. And now you've got the lunatics out there who are, some of them started out as not being lunatics, and some were lunatics from the get-go, you know, are ruining this situation for people who legitimately need pain medication. And the CDC guidelines, we can talk about them. I don't think they're that draconian. There are some more guidelines that are significantly more draconian, including those at the Veterans Administration that would be. I don't practice at the VA. I only know what I hear. So I can.
Right.
But they're look. All of these people, including the CDC, are trying to make a situation that seems out of control better. They really are trying to do that. Now, what's happening to me is that they're throwing the baby out with the bathwater, that there are people who legitimately require pain medication, including my patients who are 100% cancer pain patients, right, are having a hard time getting their medication, where they're having, 5-day trials, so they got to keep going back to the pharmacy to get their medication, prior approval on 100% of all opioid prescriptions, stuff like that, things that are just making it difficult for people who actually need these medications. And I don't know what the answer is, but Patty, go back and tell us a little bit about your situation and how you became a chronic pain patient, and now what's going on with you that prompted this call.
Well, for me, it started about 24 years ago. I was in a horrific auto accident on the highway. I was hit by a Mack truck at 70 miles an hour.
Okay.
And it just literally, for the medical term, is it smashed my back up.
Sure.
And after 5, the specialist looked at it. They said, we can't repair it. There was too many bones smashed together, and it was just unfixable. But they said at that point, we can make you comfortable enough. then there were 2 other accidents. People flew through red lights. And, as the years went by, they found a good dose that worked for me pain-wise. And I'd been on the same dose for the last 18 years.
Okay.
And it worked great, and never abused it. And if I needed to have it filled early, I have this great dog, and I always let him know, here's what's going on. And I have history with him, so he knows there's no abuse going on. Suddenly, it wasn't suddenly, but it was sudden for me. Last August, my doc said, we are now going to slash your medicines from 120 milligrams a day, 90 for pain, 30 milligrams for breakthrough pain, to 30 milligrams. And that happened within 3 months.
Okay.
And many people are facing this.
Was there any indication for this other than
no problem?
Oh, sorry. Was there any indication for doing this other than that people are starting to freak out about pain medication? Was there any medical indication for decreasing your pain medication?
No, and the reason he told me, and he was very candid with me, because we have a very open relationship, was that these are the new CDC guidelines, and we are being told from the DEA, if we do not do this, we are subject to being prosecuted.
Right, or both.
And
both.
That's pretty much been that's pretty much been the story all along. I mean, there was no problem with my meds, and the CDC came in, and they use this word opiate crisis, but what they don't differentiate is that illicit fentanyl, heroin, those are opiates too. Mm-hmm. So they were trying to make a drug war better, but instead the pain patients got slammed, and now doctors, you guys are having to do the monkey dance all day long with paperwork, and it's a bad situation all the way around for many pain patients. I've heard from hundreds.
This is what I've seen, is the CDC guidelines don't say if you have someone on a stable chronic dose and there's no signs of diversion, take them off their medicine. There's nothing in the CDC guidelines that say that. What's going on is these doctors are, and not all of them, but there are some that are getting scared because they think these things are going to happen. I haven't heard the DEA ever say, we're going to prosecute you if you treat pain patients appropriately. Matter of fact, I had 2 DEA agents show up in my office one day, and I got a phone call from my office saying 2 giant men are in your office and they want to see you right now. Yeah. So I went running down there because knowing what I do for a living, I figured at some point I would be on their radar screen. Mm-hmm. I legitimately treat patients, but they're all, it's very severe cancer pain. Mm-hmm. And I only see the ones that the regular oncologist can't handle. Mm-hmm. So I went running in there, and yes, indeed, there are these 2 giant men mountain in my office. And they asked me my name. I said, yes, it's me. I said, this is a friendly visit, right, guys? And they handed me a subpoena. But they wanted me to testify against somebody else who was doing a pill mill. Unfortunately, our 2 subspecialties were different, so I really couldn't help them because, I would have been, it's like apples testifying against oranges. Sure. So, but while they were there, and it was a very friendly visit, I asked them, am I ever going to be on your radar screen? They said, what we're going after are people who are seeing 100 people a day. They're doing cash only, and every single person that comes in gets 90 OxyContin, 40s, and 180 Roxycodone 30s. And it's like they've got a rubber stamp, boom, 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 boom. And that's what they're looking at. And they said, you who are individualizing your treatment, who are treating your patients appropriately, will never be on our radar screen. Well, I wish every doctor who treats pain would hear what they had to say about that, as long as we are treating, and I'm knocking on wood when I'm saying this, because sure as shit, tomorrow they'll show up on my doorstep after I said this.
Today's episode is brought to you by Angie. Angie has made it easier than ever to connect with skilled professionals to get all your jobs and projects done well. Let me tell you, there's the version of it where you try to do something at home, and then there's a version of it where you have someone help you, you watch them do it the right way, and you go, thank God I didn't try to do that myself. I have fully done things around the home that I think look good, and then a bang in the night, and I wake up to a shelf collapsing, a painting falling off the wall. I've seen it all go south. I own a home, and I can tell you, I know how much work it can take. Whether it's everyday maintenance and repairs or making dream projects a reality, it can be hard just to know where to start. But now all you need to do is Angie that and find a skilled local pro who will deliver the quality and expertise you need. Whatever your home project, big or small, indoor or outdoor, you can Angie that and connect with skilled professionals to get the project done well. Right now, one of my wish lists is I want a bike for my condo in Milwaukee, and I would love to rig it up on a pulley in the ceiling because I have one of those lofted ceilings, but I'm so scared to try that on my own. Angie has 20 years of home experience, and they've combined it with new tools to simplify the whole process. Bring them your project online or with the Angie app. Answer a few questions and Angie can handle the rest from start to finish, or help you compare quotes from multiple pros and connect instantly, which means you can take care of any home project in just a few taps. Because when it comes to getting the most out of your home, you can do this when you Angie that. Download the free Angie mobile app today or visit Angie.com. That's ANGI.com.
But
Right.
I wish every doctor would hear this because they don't have to fear if they're treating people appropriately using the minimum dose, of course, the minimum dose required to do the trick, and documenting what they're treating. The biggest thing that people get in trouble with is when they're documenting or when they're treating for an indication that they haven't documented for. For example, the patient told me I had cancer pain, or the patient told me they had arthritis, and you haven't done a workup to prove that they do have arthritis. You know, Dr. Scott works at a pain clinic. Now he does all the non-opioid stuff, you know.
Yep.
Why don't you talk for a second about what you do to alleviate this problem? Because not everything has to be treated with opioids, that's for sure. Patty obviously does.
Yep.
But talk a little bit about what you're doing.
Well, I'll tell you exactly what Dr. Steve just said. You know, the problem we have is that working in a pain medicine clinic, we get a lot of the patients that none of the other doctors want to write medicines for because they're afraid, because they're on high doses just like you, Patty. And so what we try to do is...
And by the way, most of my cancer patients would laugh at how much Patty was on before they reduced her.
Oh, yeah.
But anyway, go ahead.
Yeah, that's true. And so what we do, Patty, is we try to give the patient some alternatives and some comprehensive approaches. We do. Of course, I do the acupuncture and herbal medicines for pain. We have physical therapy. We have psychological help. We have every kind of modality you can ever use to help treat pain. And I'll give you, for instance, I had an instance last night with a family member who broke his leg. Okay, he went to the emergency department. They're waiting for the swelling to come out of it. The doctor writes him for pain medicine. You know,
right?
So last night I go over and I'm like, well, how are you feeling? Okay, but I need my pain medicine. Why do you need your pain medicine? Because he told me I could take it every 4 hours. And that's one thing I corrected him on. I said, listen, this is where a lot of the trouble is. When you read your prescription, it says, take every 4 hours. That doesn't mean...
It should say every 4 hours as needed.
As needed, right.
As needed, yeah.
And so we work on that. But, a chronic pain patient that's been on well-controlled medicines for years, I've never...
I don't see an indication
seen any need to change. And that's what we do.
Hey, Patty, what do you think of Dr. John Sarno's book that says, are you familiar with that? And I wonder what the chronic pain patients feel about that. Howard Stern's always talking about him. That says that chronic pain, back pain, is just in everyone's head, that you don't need anything. I know, exactly.
Yes,
right?
I've been trying to perfect the method to think it away. I'm not quite there yet.
Yeah.
I don't mean to be sarcastic, but most chronic pain patients have we'd like to incorporate the options with the pain medicine. And if we could just do the options, we would love that, because taking pain medication was not on my bucket list.
Right. And anyone that's only prescribing that, and hold that thought just for a second, because if I don't say this now, I'll forget what I was going to say.
Understand.
If we never want to only prescribe opioids for chronic pain, and I'll tell you why. That's what got the Romans in trouble. The Romans would, when they were in battle, they would line up, and they would, the other army would line up, and they'd come to each other and start poking each other with swords and sticks and stuff, right? And then the Vandals.
That sounds right.
The Vandals said, well, this is fucking stupid. Let's just go around the side and flank these people. We can beat the shit out of them. And indeed they did. And I'm vastly oversimplifying the fall of the Roman Empire. But,
right.
Using a multifaceted, multi-front approach to battling anything is always preferable to a heads-on, single modality approach. So I think the same thing is true when we're treating chronic pain. It's like a battle, and we've got our frontline artillery, which may be chronic opioids, and then we've got all these other things that we can then flank the pain. And the more modalities we use, the less of each one that we can use.
Exactly.
So now what were you going to say, Patty? I interrupted you. I apologize.
Oh, that's quite all right, because I love listening to you guys talk, so no worries there. I was going to say, I don't know if you're aware of Dr. Forrest Tennant in California.
I am not.
He does, it sounds like what you do, Dr. Scott. He deals with a lot of pain patients with complex pain issues, and he refused to slash their doses, and then the DEA came and investigated him and shut him down. Of course, I don't know how that trial is going, but it has gone from where they were guidelines to now they're laws, and I think the big thing that's frightening.
But they're not. They're being interpreted that way, but they're not laws. Even in the state of Tennessee, we have chronic pain guidelines that are truly guidelines. The guidelines even say we expect that these guidelines will be deviated from in certain cases. I don't know this, Dr. Tennant, that it's all going to boil down to whether he documented what he was doing properly, because that's the key to all of this is saying, what am I treating? What's the indication for treating with opioids? I tried A, I tried B, I tried C. Now we're doing chronic opioids. These people are not diverting. I'm doing urine drug screens. I'm doing pill counts. I'm screening them for mental illness, all of this stuff. If you document all of that stuff, I would be very surprised. And if he did document all that stuff, I would be happy to volunteer as an expert witness to testify on his behalf. And I know there are lots of other pain people would as well, because that's just standard of care. Now, if he didn't do that, he's going to be in a bit of a pickle when it comes to defending himself if the DEA or whoever, I don't know who it is that targeted him, has decided to come after him.
Yeah. Well, and I don't want to ramble on and chew up all your time.
No, it's okay. This is a good topic.
Comes down to this, that the most frightening thing is for people who were stable, had provable pain, were compliant pain patients across the nation, they've either been abandoned by their doctors for fear of the DEA, or they've had meds slashed, and that's just, it's, as a pain patient, you're like, where do I go? What do I do? I mean, your only option is to try to fight back. And I think it's just scary to me that people are being left in pain,
I give talks to large medical groups, and one of the things that I always tell them is that it upsets me when I hear doctors say to me, and I have people who I respect who are colleagues, well, I just don't treat pain. And that's like, why don't you just say, well, I just don't treat diabetes, or I just don't treat hypertension. And if you're not going to treat it, that's your prerogative, but send them to somebody who will. Develop a relationship with somebody who will. Because if I say, I ain't go treat no diabetes, I got to send those people to an endocrinologist.
And don't beat the person up for having pain or for having diabetes, because that's what we get. And then the patient feels like they're a bad person.
Because here's the problem.
Yes.
We don't have a blood test for pain. If we did, this would be a different story because it affects people's behavior. And okay, so let's talk a little bit. Yes. Andy, I'm gonna put you on the spot on this. I need you to get close to the microphone. Yeah. If you had 10 out of 10 pain, let's say you had some tumor in your leg or something that was causing horrific pain, and I said, oh shit, it's all in your head, and I gave you Tylenol for it, how would you behave? What kind of things would you do to try to rectify this situation.
Well, I mean, if you're talking about 10 out of 10 pain, I mean...
10 out of 10.
Right.
Worst pain you can imagine.
I mean, I feel like Tylenol will only take you so far, and then,
Right.
you would get to a point where you would be at a loss, and, maybe you would...
So what would you do?
Consider looking at other alternatives.
Like what?
Well, I mean, the obvious thing would be, I think you'd start talking about it with people, and then you're going to find somebody that knows somebody who knows somebody that's had similar issues.
So you're going to go to another doctor?
Perhaps.
Okay, that's doctor shopping. Okay, number 2, what would you do?
Maybe that doesn't get you anywhere either, but, maybe, hey, listen, I've got something for you that's going to maybe alleviate some of the pain that you're having.
So you're talking about you get something on the street?
Possibly.
Okay, so you get something on the street, so now you're using street drugs. What else? What else would you do?
Self-medicate with alcohol. I mean,
so now you're a substance abuser.
Exactly.
How about anybody else throw some stuff in? I put Andy on the spot. You might raise hell in the doctor's office. You might slam the door. You might yell in the lobby.
We have people going out slamming doors, throwing shit down the hallway. Yeah.
So these are all drug-seeking behaviors. These are all behaviors that we associate with addiction.
Right.
But this is not an addicted person. This is someone that is simply seeking relief.
Yep.
And it is almost impossible to determine who's an addict and who's a pseudo-addict, which is what we're describing here. So you know what the answer is, and it's counterintuitive. You increase their pain medication. The pseudo-addict will go, oh, thank you, finally. Thank you, I've got some relief. Whereas the addict, there's they're a bottomless pit. There's no end to what they will.
Right.
So we hear these kind of vignettes all the time of people in these desperate positions. Are you seeing anything, and not to flip the subject, but are you seeing anything where people are hesitant to have procedures or go down the road of even being offered these pain medicines because they feel like, they're 2 steps away from doing an intervention.
Well, and they're afraid of being addicted. That's exactly
sure.
right.
Or being thought that they were addicted. I have people that say, I don't want to take that medicine because I don't want people thinking I'm a drug addict.
Right. I'm a drug seeker. Yeah.
Or they say, I don't want that stuff in my house because people are just going to break in my house and knock me over the head and take it from me. And so there are people out there that are abusing the shit out of this stuff, and they have ruined it for the Patties of the world.
Yep.
And
right.
Overprescribing ruined it for the Patties of the world. Abusing the system, where people were taking truckloads of people down to a certain state south of us, and were getting MRIs and getting prescriptions for stuff, and then getting a 3-month supply of medication that they would then bring back up here and then distribute. That ruined it for Patty. And, so this knee-jerk reaction is, well, we got to do something. Well, let's make things more strict for everybody. And the problem is Patty is suffering.
Yeah, it's kind of they made it a one-size-fits-all, and that never works.
Right. No. I agree. No. If the physicians out there and other providers that are prescribing would read the CDC guidelines, they really aren't that draconian. They really aren't. You got to read them. They would just basically say use the minimum amount required to do, and do due diligence. Make sure you're treating for a proper indication, and you are not overprescribing it. That you're not dealing with aberrant behavior and that kind of stuff. And it doesn't. And nowhere in there does it say every doctor take all your patients off of their medication. So I think once
it started out as
go ahead.
Sorry.
Go ahead. No.
It started out as guidelines, suggestions, but even before the full force of this had taken place, there was this rampant fear that the DEA had really kind of pushed on all these insurance people and the insurance doctors, and the doctors had to go to seminars about these guidelines, but nobody was willing to do the guidelines. They did what was recommended by the MME. The CDC MME, and it's left atrocities. And I think next year or so, people in general are really going to be shocked by the atrocities that it's kind of laying out.
I think there will be a backlash.
Severe change.
People like yourself will get your voice heard. The press loves this kind of story. And it will get out there, and people will realize that they will realize eventually things will settle down that the DEA isn't going to come after them just because they're treating appropriate pain. And that's really where the answer in this lies, is with education. Now, I do the 2 hour. In Tennessee, we have to do 2 hours of CME every 2 years on what's called safe opioid prescribing, and I give those talks. I'm the one who gives the talks, and nowhere do I ever say, take all your patients off their opioids. We're always talking about how to safely prescribe them. Start low and go slow. And monitor, give people naloxone, do urine drug screens, screen for mental illness, all these things so that you can safely prescribe. And I'm hoping that as this education spreads out there, that people will just start calming down a little bit. You know, it's a tough situation.
I hope so too.
But I'm sorry that you're going through this, and you know. If you turn around and try to find another provider who may be more liberal in their prescribing than your prescriber who's decided that they're going to be afraid to prescribe anything, you're going to be labeled as a doctor shopper. So there is a way to do this, though. You could ask your prescriber to refer you to somebody that might be more comfortable doing this. And they may be glad to do that, to be honest with you, just to not have to deal with it. And you could still, if I'm assuming is that your primary care provider?
It is right now because I don't have a car, and Denver is 60 miles from me. So
you're in Colorado?
It's been very good, you know.
You're in Colorado?
Yes.
So have you tried, I'm just asking, I'm not recommending this, have you tried marijuana as medicine? And did it give you any benefit?
You know, here's the double-edged sword. It violates my pain contract. I would like to try it.
Isn't that fascinating?
But it violates my pain contract.
Study after study has shown that people who use marijuana as medicine use less opioids. You know?
Well, I'd love to have it as an option, but if they, they can say to me, "Sure, go ahead and try it." But if you don't put that in writing in my pain contract, you can then drop me for violating my pain contract. Right. So it's a double-edged sword.
That is not a double-edged sword. That is what you call a catch-22. So, okay. So this is what
a dagger. Let's just call it what it is.
This is what I'm going to recommend to you: is that you go to your primary and say, "Look, I know you're uncomfortable writing this stuff because there's so much pressure being put on you. What do you think about referring me to a chronic pain clinic that might be a little more comfortable doing this stuff?" And just see what they say. Because if you go on your own, of course, now you've got 2 pain contracts out there. That's not cool. But just to say, to find somebody, and there's got to be somebody in the metropolitan Denver area or in your area that treats pain appropriately. And this isn't even to say that your primary care isn't operating in good faith. They think they're doing the right thing. They've been your provider for 18 years. They don't think they're doing the wrong thing. You know,
exactly.
So, but anyway, I hate that for you. Let me try that and let me know how it goes.
Thank you.
And take heart. I do believe this will get better as the backlash kind of hits the press. And I know there's some of the people on Twitter are saying, "Oh, the press has been bought off." Bullshit. They love a great story, and they love a great story where the little guy is going after the big guy and all that stuff. And I really think
going after the man.
That they're going to take this story up, and you'll see a lot more interest in this as time goes on.
Well, so they just haven't caught up with it yet.
No, not yet.
So I'm
but they
looking
will.
forward to that.
Okay. Well, I really appreciate you calling in.
Thank you so very much,
story.
Dr. Steve and Dr. Scott and Andy.
Take
Have
care.
a great show, and my kitties are all talking at once. Of course they are.
And tell all the other CPPs to leave me alone. I'm doing the best I can. Jesus, I'm just one person.
Good luck, Pat. Take care.
Have a good day, guys. Bye-bye.
Bye-bye.